wonderful students. We are now going to talk about opioids and analgesic agents. This is going to be an important chapter, and I would recommend that you fill out medication templates for these meds. We have morphine. It is an opioid agonist. The short-acting version of morphine sulfate is MSIR, or morphine sulfate instant release. Long-acting is MS-Contin, or morphine sulfate extended release, or MSER. Remember the extended, we talked about this last week, the extended versions cannot be crushed, right? But the short-acting can. We have oxycodone in the opioid agonist version. Again, short-acting version is oxy-IR. Long-acting is oxy-ER. And there is a short-acting version that has acetaminophen in it. It's called Percocet, and we give a lot of that out. Percocet, again, has oxycodone and acetaminophen in it. And then we have, we talked about the long oxy-ER. Please know, you do not substitute an immediate release for an extended release. They are not the same chemically. They work very different in the body, and therefore you cannot, same thing, you really should not, you cannot substitute Percocet for oxycodone itself, right? Because Percocet has acetaminophen, which is a medication. Irregardless, it's over the counter. If you're at a facility or you're a nurse, you have to have a prescriber give you an order, even for over the counter meds, okay? So don't substitute them. Another opioid agonist, hydromorphone. Hydromorphone is for severe pain, typically related to cancer or sickle cell disease. It is 7 to 10 times more potent than morphine. Hydromorphone is 7 to 10 times more potent than morphine. And it's important to note that there is no long-acting version of hydromorphone here in the United States, okay? Fentanyl is also an opioid agonist. It's also for severe pain. We use it, again, for cancer and sickle cell patients, as well as for procedural sedation. A lot. We use all of these meds for a lot of things. Fentanyl is 100 times more potent than morphine, and we dose it in micrograms instead of milligrams, okay? And again, it's injectable, patch, pill, you name it. Opioid agonists acts on the opioid receptor sites in the central nervous system, and they act on them by providing a sedative, analgesic, and an overall sense of well-being, right? It's really uplifting. We give it for severe acute pain, severe chronic pain. We give it for analgesic methods during the OR, right? And they do cross the placenta. Which of course will come into play when you're pregnant or giving it, pregnant mothers, right? Opioid pharmacokinetics, it is available in oral and injectable forms. Don't mix morphine with other injectable meds. Please pull them up in different syringes and administer them differently. And if you are going to combine them, you better be very careful and make sure that the meds are compatible. It's important to note that oxycodone is only available in oral form, and oxycodone with acetaminophen can be very hepatotoxic in very large doses, so be very, very careful. And it's important to note, because of intracranial pressure, these meds are contraindicated in significant brain injuries, okay? Because they do cause elevation in the ICP, or intracranial pressure, right? And in your head, you only have so much room, and if your brain swells up more than the room that's in there, your brain will herniate out the back and you die, right? You die. Okay, again, when we give opioids, we are always going to be assessing the patient's respiratory function, because we know it suppresses the respiration. So we know that it's going to have a lasting effect, and we expect it to happen, right? And we also know that it slows down the GI motility, so the patients are going to have decreased peristalsis, which results in constipation is one of the things, right? And some GI distress in some patients. Some adverse reactions that could happen, this is extremely rare, but it can cause apnea in some patients. That's why we're regulating and monitoring the respiratory status. It has also caused psychosis in a very small percentage of patients. And it can lead some patients into shock if there's a significant brain injury, but again, it's rare. All of these are pretty rare. Opioid agonist side effects include orthostatic hypotension, constipation, biliary spasms. So we're going to do these educations when we're doing all of our educations about our pain meds to our patients. They do have drug-to-drug interactions, so we got to watch them very closely for any other meds that suppress the CNS, the central nervous system. So that includes benzodiazepines, right? So medications for anxieties, all kinds of things. So when you're setting up your template, make sure you're including those drug-to-drug interactions, especially for meds that we give all the time, right? So here's the prototype for your morphine. And again, this is great medication that we use all the time in the hospitals, in hospice, in the homes, home health, all kinds of stuff, right? And again, it's to relieve moderate to severe pain, acute or chronic. It's a preoperative, postoperative medication. We use it many combination therapies for chronic pain patients. And definitely use it for intractable pain. It works as an agonist on the mu opioid receptor sites. It provides not only the analgesic effect, but also euphoria and sedation. That's why we use it a lot. I would have a general, you don't need to memorize the onset, peak, and duration, but you should know based on if you give something IV versus oral, it would take IV a few minutes versus oral a half an hour, for 15 minutes to 30 minutes for the meds to start to work, right? If you take those routes, have that idea. And also know, you should though on each of the meds know that about how long the peak is, so that especially just the two routes for IV and peak, because you want to be able to come back in and see whether or not it was effective, right? And then of course adverse effects, you want to write those down as well on your template, your medication template. Okay, you always want to know what the antagonist is of each medication so that you have it ready in your head to administer if something bad was to happen with your patient, right? And so for this opioid antagonist, we would use Narcan or naloxone. It literally reverses the adverse effects of the narcotics by knocking off the opioid on the receptor sites, right? And therefore it will allow a patient not to die from it, right? Hopefully, if we catch it in time. So again, it has a stronger affinity to the opioid receptor sites than the pain med itself, right? But what's cool about it is it doesn't activate the receptor site. All it does is it kicks off the pain med from that site. And therefore, it will literally reverse the effects of the opioids, right? When do we use opioid antagonists? When we want to reverse the effects of the narcotics working too strong or adversely, or we need to treat alcoholic dependence or narcotic dependence as well. So you can give it sub-Q, IM, IV, or orally. And there really aren't any indications, but I will tell you that when you give a patient who's like an addict, like let's say, for example, a heroin addict, naloxone, be ready for them to come out, they're brought immediately out and quickly out of their high, and many times they come out raging. So just be expected, you could see some behaviors because they're, again, coming out of that high pretty quickly, right? So they might go in withdrawals real quick, is what I'm trying to say. Okay. It can cause side effects like tachycardia, blood pressure changes, dysrhythmias. Okay, the combative behavior I just mentioned. It can cause that acute disorientation and vomiting, right? Because of the withdrawal symptoms too. There are some drug-to-drug interactions. So if patients are on buprenorphine or other opioids and stuff like that, it's definitely going to have a drug-to-drug interaction. Excuse me. We should be aware considerations for opioid agonists and antagonists. Clearly be aware of the patient's entire vital signs, right? Blood pressure, heart rate, respiratory rate, neurostatus, all of that, cardiac output, their muscle spasms, flexes, affect, all of their pupil size. Definitely want to look at pupil size, right? Bowels, listen to the bowels. We want to make sure that they are still having bowel sounds in all four quadrants and that the bowels aren't distended, right? We want to look at liver and renal function tests to ensure that they have proficient and sufficient perfusion of their organs to be able to break down and get rid of these meds, those kinds of things, right? There's the prototype for naloxone. All right, this is the end of this part.